So we're going to review about the word black since it's a word that comes a lot. First of all, condensing osteitis. So in dental decks, we can see a question that is asking about a healthy patient that comes into the office for an initial exam. On the full mouth series of radiographs, you see a radiopaque lesion periapical to tooth number 19. Okay, tooth number 19 has a deep amalgam restoration with recurrent decay underneath. You can see the entire outline of the mesial root of tooth number 19. The lesion seems to stem from the tooth. What is the most likely diagnosis of the lesion? The answer is, again, well, again, the question, healthy patient comes into your office for initial exam. On the full mouth series of radiographs, you see a radiopaque lesion periapical to tooth number 19. First molar. Tooth number 19 has a deep amalgam restoration with recurrent decay underneath. You can see the entire outline of the mesial root of number 19. The lesion seems to stem from the tooth. What is the most likely diagnosis of the lesion? Condensing osteitis. Condensing osteitis is a diffuse radiopaque lesion representing a localized bony reaction to a low-grade inflammatory stimulus, usually seen at the apex of a tooth. Symptoms for condensing osteitis include focal sclerosing osteomyelitis, bony scar, and sclerotic bone. Condensing osteitis may be found at any age but is typically discovered in young adults. Patients are usually asymptomatic and most lesions. So, again, the periapical X-ray demonstrates a pathognomic, well-circumscribed radiopaque mass of sclerotic bone surrounding and extending below the apex of one of the or both roots. The entire root outline is almost always visible. An important feature in it distinguishing it from the benign cementoblastoma, which radiographically it may be similar. The tooth with the lesion, again, okay, let's make a point there. The entire root outline is almost always visible, and that's an important feature in distinguishing it from a benign cementoblastoma. Okay, condensing osteitis, you will see an entire root outline, which will almost visible, which is almost always visible, which radiographically it may resemble. The tooth with the lesion may be treated or extracted since the pulp is infected and the infection has spread past the immediate periapical area. Diffuse sclerosing osteomyelitis was another of the options, but um, no, it was not an option, but diffuse sclerosing osteomyelitis represents an inflammatory reaction in the mandible or maxilla believed to be in response to a microorganism or of low virulence. Important in the etiology and progression of diffuse sclerosing osteomyelitis is chronic periodontal disease, which appears to provide a portal of entry for bacteria. Again, important etiology and progression of diffuse sclerosing osteomyelitis is chronic periodontal disease, which appears to provide a portal of entry for bacteria. The condition tends to occur most frequently in middle-aged black females. Again, diffuse sclerosing osteomyelitis represents an inflammatory reaction in the mandible or maxilla believed to be in response to a microorganism of low virulence. Important in the etiology and progression of diffuse sclerosing osteomyelitis is chronic periodontal disease, which appears to provide a portal of entry for bacteria. The condition tends to occur most frequently in middle-aged black females. The disease is typified by a protracted chronic course with acute exacerbations of pain, swelling, and occasional drainage. Radiographically, this process is diffuse, typically affecting a large part of the jaw. The lesion is ill-defined. Treatment consists of determining and addressing the cause. Antibiotics are the mainstay of treatment. Low-dose corticosteroids have also been used with some success. Hyperbaric oxygen therapy may prove to be a valuable adjunct. Okay. Um, Periapical cement. Next question. Periapical cemental dysplasia has a predilection for middle-aged black women. Remember, this lesion, also known as periapical cemental osseous dysplasia, represents a reactive rather than a neoplastic process. This lesion appears to be an unusual response of periapical bone to some local factor. Okay, this is relatively common phenomenon that occurs at the apex of vital teeth. Women, especially black women, are affected more than men. It appears in the anterior periapical region, is far more commonly affected than is the maxilla. More often, the apices of two or more teeth are affected. There are no symptoms and the teeth are vital. As the condition progresses or matures, the loosened lesion develops into a mixed or mottled pattern owing to bone repair. The final stage appears as a solid opaque mass, often surrounded by a thin, loosened ring. No treatment is required for this condition. A rare condition A rare condition called florid cemento-osseous dysplasia appears to be an exuberant form of a periapical cemento-osseous dysplasia. It is common to see this condition in the posterior as well as the anterior regions of the mandible. This cementifying fibroma occurs chiefly in adults around age 40. There are predilections for the body of the mandible and for females. The lesion may cause tooth movement or cortical expansion. Radiographically, it is well circumscribed and may appear relatively radiolucent. Lucent with opaque foci or diffusely opaque. It is treated with curettage or excision. Recurrence is very rare. This lesion can be considered similar or identical to the ossifying fibroma. Next question. A 45-year-old African American female presents to your office for a routine exam. Periapicals of the mandibular incisors show multiple radiopacities with radiolucent rims. Tip number 23 through 26 test as vital. There is no pain on percussion or palpation. Treatment of these lesions should be do nothing. Do nothing. Why? Because this is a periapical cemental dysplasia, also known as periapical cementoosseous dysplasia, and formerly known as cementomas, represent a reactive rather than a neoplastic process. The term cementoma is a misnomer as the opacities are not cementum but bone. While they appear to arise from the teeth, the lesions apparently arise from the bone instead. It appears to be an unusual response of the periapical bone to some local factors, for example, traumatic occlusion or infection. What are the clinical features? They occurs at the apex of vital teeth, a predilection for middle-aged black women, asymptomatic, usually multiple small periapical areas of radiolucency in the mandibular incisor area. You can see that in the booklet on picture number 53. Depending on the stage, it may appear mixed radiolucent and radiopaque or totally radiopaque. Important factors are age, gender, location, radiographic appearance, and tooth vitality considered together are diagnostic for this condition. Age, gender, location, radiographic appearance, and tooth vitality. So osteolytic stage, in the osteolytic stage, there's a radiolucency that appears on the Osteolytic stage, there's a radiolucency that appears on the radiograph. On the second stage is the osteoblastic stage, in which a in which a beginning of a calcification in the radiolucent, in which there is a beginning of calcification in the radiolucent area. Mixed radiolucent and radiopaque appearance in the radiograph. And the third one, which is the mature, when it's a sclerotic stage. There's radiopacity that appears on radiographs with a thin radiolucent line around the area. Note, no treatment is required for cementomas. Okay? Once this stage is reached, the lesion stabilizes and causes no complications. Remember that the word is not cementoma anymore, although it can be asked like that, but it is periapical cemental dysplasia. And this is not really cement, it's bone. So, next question. A 5-year-old boy presents with his mother for his first dental exam. Your exam reveals a normally developing dentition, but you notice multiple freckles on his lower lip and on the buccal mucosa. What condition should you be concerned about? Answer: Peutz-Jeghers syndrome.
Peutz-Jeghers syndrome.
Okay, let's see how it's said.
Peutz-Jeghers syndrome.
Peutz-Jeghers syndrome. Peutz-Jeghers syndrome. So, in Peutz-Jeghers syndrome, which is also called hereditary intestinal polyposis syndrome, the Peutz-Jeghers syndrome is an unusual condition that is of interest to the dentist because of the oral findings. The pigmentations usually appear at an early age, often during the first decade of life, and at this time are restricted to the oral region. Intraorally, these pigmentations may be located anywhere on the mucosa, but are most frequently seen on the buccal mucosa, gingiva, and hard palate. The mucosal surface of the lower lip is almost invariably involved. These spots are macules, while of variable intensity may range through shades of brown, blue, and black. During the succeeding decades of the patient's life, pigmentations may arise elsewhere in the skin, especially in the extremities. In addition, intestinal polyposis is seen most commonly in the small intestine, the jejunum, and may produce signs and symptoms of abdominal pain, rectal bleeding, and diarrhea. It should be noted that the pigmentations of Peutz-Jeghers syndrome may occur without demonstrable evidence of polyps, and also that multiple polyps may be encountered without pigmentations. It is significant to note that although the oral pigmentations per se are harmless, the presence their presence is important because they indicate a necessity for investigating the possible presence of multiple polyposis, which may prove harmful. There is a strong tendency for these multiple polyps on the colon to undergo malignant change. It appears to be caused by a mutation of the gene known as LQB1 of chromosome 19 that includes multifunctional serine threonine kinase. Well, okay. Next about lack. What most likely is cause the discoloration of the gingiva as seen in the picture below? There is a discoloration of the gingiva. Okay. An amalgam tattoo is the most common oral pigment lesion. The tattoo has been mistaken for a melanin pigmented lesion. The most common location for amalgam tattoos are the gingiva, buccal mucosa, and alveolar mucosa. Trauma and chemicals are frequent causes of oral lesions. An aspirin burn occurs when patients place a tablet against an aching tooth, allowing the cheek or lip to hold in position while it dissolves slowly. Within a few minutes, a burning sensation of the mucosa will be noted, and the surface becomes blanched or whitened in appearance. The caustic action of the drug causes necrosis of the oral mucosa with subsequent need to know how to pronounce this word.
Slough.
Sloughing. Subsequent
Sloughing.
sloughing. Okay. With subsequent sloughing. With subsequent sloughing of the necrotic epithelium. Note: attempt to locate amalgam on X-ray if tattoo is suspected. If you cannot locate any amalgam, a biopsy may be needed to rule out a melanocytic neoplasm. Remember, chemical burns may also be caused by hydrogen peroxide, silver nitrate, phenol, etc. The use of the heavy metal bismuth is still common in treating certain dermatologic disorders as well as various other diseases. Bismuth pigmentation appears as a bismuth line. Let me see if I'm pronouncing that right. Bismuth.
Bismuth.
Bismuth. So, bismuth chemical burns may also be caused by hydrogen peroxide, silver nitrate, and phenol. The use of the heavy metal bismuth is still common in treating certain dermatologic disorders as well as various other diseases. Bismuth pigmentation appears as a bismuth line, a thin blue to black line in the marginal gingiva that is sometimes confined to the gingival papilla. Note: lead ingestion also leaves dark marks on the gingiva. Okay, bismuth is used for some medical treatments, dermatological disorders, and they leave a gingival, they leave a black to blue line in the margin, no gingiva that is sometimes confined to the gingival papilla, but lead ingestion also leaves dark marks on the gingiva. Traumatic ulcer. Traumatic ulcer is a very common, may mimic oral cancer and chronic infections, ulcers. Focal keratosis. Focal keratosis are common white lesions caused by chronic friction of the mucosa. Important, differentiated from idiopathic leukoplakia because cause is known. Okay? Idiopathic is not known. Focal keratosis is a chronic friction of the mucosa. Linea alba is a type of frictional keratosis that appears as a linear white line in buccal mucosa. Smoking associated melanosis is caused by a chemical in tobacco smoke that stimulates melanin production. Note, if the pigmentation is localized and ulceration is present or the lesion is elevated, a biopsy is necessary to exclude other pigmented conditions, nevi or melanomas. Although smokers' melanosis is an abnormal deformation of melanin, the lesion itself is not associated with an increased risk of melanoma or carcinoma. Melanotic macule, most common melanotic lesion. Most common melanotic lesion, melanotic macule. Gingiva, a common location called an oral melanotic macule, and the lips are most frequently on the lower lip, called a labial melanotic macule. It can be associated with Peutz-Jeghers. And there's drug-induced pigmentation, most commonly associated with minocycline, chloroquine, cyclophosphamide, and azithromycin. Okay. Next question that mentions the word plaque. Oncocytomas are rare tumors that constitute about 2% of benign epithelial salivary gland neoplasms. Oncocytomas. The term monomorphic adenoma refers to a group of rare saliva root tumors that include the basal cell adenomas, canalicular adenomas, sebaceous adenomas, myeloepitheliomas, and oncocytomas. The question is asking about oncocytomas and what are they and what is the percentage in the benign epithelial salivary gland neoplasm. So, oncocytomas are rare tumors that constitute only 2% of benign epithelial salivary gland neoplasms. The majority of these tumors affect the parotid gland, 78% of them, oncocytomas. But oncocytomas are only the 2% of the benign epithelial salivary gland neoplasms. The clinical presentation of oncocytomas is essentially identical to the other benign salivary tumors. A slow-growing, non-tender mass, typically in the superficial lobe of the parotid. Microscopically, there are sheets, nests, or cores of uniform oncocytes. Basal cell adenomas are also rare tumors that constitute only 3% of benign epithelial salivary gland tumors and typically occur in the sixth decade of life. It seems to occur most frequently among Caucasians than African Americans. The majority occur in the parotid gland where they present a slowly enlarging firm mass. They are well encapsulated, smooth tumors on gross inspection and are divided into four subtypes based on their microscopic appearance: solid, trabecular, tubular, and membranous. Canalicular adenomas are also rare tumors. It's only 1.5 of them that most commonly involve the minor salivary glands of the upper lip, 74%, and 12% in mucosa, canalicular adenomas. It peaks in the seventh decade of life, and like the basal cell adenoma, is most common in whites than blacks. Clinically, it presents as a non-painful submucosal nodule. On gross pathologic examination, canalicular adenomas may or may not possess capsule, and it is not unusual for there to be multifocal growth. Multifocal growth. Microscopically, there are cores of single-layer columnar or cuboidal cells forming duct-like structures in the background of fibrous stroma. The rare myoepithelioma accounts for less than 1% of the salivary gland neoplasms. Most arise within the parotid gland, less frequently in the submandibular gland and intraoral minor salivary glands. These patterns of microscopic appearance have been described. The spindle cell pattern is the most common overall and is typically the parotid myoepitheliomas. The plasmacytoid pattern is less common. Okay. Note, cyaloscintography is a simple and non-invasive procedure that can usually separate benign entities like Warthin's tumor and oncocytoma of the salivary glands from malignant tumors and significantly affect the course of the treatment. Cyaloscintography. Next question. Hairy tongue is a condition characterized by hypertrophy of the options: filiform papillae, fungiform papillae, circumvallate papillae, foliate papillae. Answer is filiform papillae. Hairy tongue is a benign condition of the tongue. The dorsum of the tongue appears furry due to can't pronounce that word. Hairy tongue is a benign condition of the tongue. The dorsum of the tongue appears furry due to an elongated papillae. The color varies from yellowish white to brown or black. It is associated with poor oral hygiene, extended use of antibiotics, corticosteroids, hydrogen peroxide, and smoking. The four types of papillae present on the tongue: filiform, fungiform, circumvallate, and foliate. The filiform is the most numerous, small cones arranged in V-shaped rows paralleling the sulcus terminalis. They are characterized by the absence of taste buds and increased keratinization. Second is the fungiform. Scattered among the filiform papillae, they are flattened, mushroom-shaped, and found mainly at the tip and lateral margins. Then the third is the circumvallate. These are the largest. They have a circular shape arranged in an inverted V-shaped row towards the back of the tongue, associated with the ductus of von Ebner glands. Von Ebner glands. They are the least numerous of all papillae. And number 4, foliate. Foliate are found in the lateral margins as as 3 or 4 vertical folds. Okay. We'll stop.